we have with us faculties from Department of Medicine, Professor of Medicine, Dr. Sujit Kumar. Really, thank you, Dr. Sujit Kumar, for joining this evening and being the faculty for this evening. We have with us Dr. Naveen Prabhu, the consultant neurologist from Meenakshi Hospital, Chennai. Really, thank you, Dr. Naveen, for joining this evening, and really appreciate your interest to join this evening teaching program. Even though last minute you're able to accept our invitation. Thank you. And we have with us going to join Dr. Manoj, is going to be the resident in the Department of Neurology, Ramakrishna Hospital, Coimbatore, is going to join soon to discuss about this case presentation. To present this case, we have with us Dr. Naveed Kumar. From Department of Medicine. The postgraduate is going to present. Over to the postgraduate and the faculties to take over the further proceedings of this session, presentation and discussion. Over to this team. Thank you.
I can start, sir.
Yes, you can start presenting. Let Sujit and Dr. Naveen take over the sessions further. Okay. Thank you.
Good evening, everyone. Good evening, Dr. Naveen and Dr. Naveed.
Good evening, sir.
All the faculty who have joined and all the panelists. I think we'll go ahead with the presentation. Is it okay with Dr. Naveen?
Yes, sir. Yes, sir.
Okay, Dr. Yeah, sure.
Okay. Good evening, everyone. We'll look at a clinical case presentation of ataxia. Mrs. X, a 45-year-old female, high school graduate, homemaker by occupation, who is residing in Coimbatore, right-handedness, with the informant as son and the patient herself, came with the chief complaints of unsteadiness while walking, associated with frequent falls for the past 7 years, complaints of chaotic movements in both upper limbs for the past 5 years, complaints of difficulty in using both lower limbs for the past 5 years, complaints of slurring of speech for 3 years, complaints of unable to swallow solids and liquids for 6 months.
1 second, Dr. Naveed, 1 second. I think, Dr. Naveen, you can like to, anytime you can interrupt and...
Yes, sir. Yes, sir.
So at this moment, anything, Naveed, would you like to, symptom-wise, before going further, at this juncture, what are all the things you'll think of?
So unsteadiness, we can think of vestibular system or cerebellum, sir, or visual. Could be because of any of the systems, sir. And chaotic movements could be associated with, it could be tremors in both
one
the
by one. So right now there is unsteadiness. So
yes,
what are all the causes for unsteadiness as of now? What do you think of?
So it could be either vestibular system, sir.
Okay.
Cerebellum, sir.
Okay.
Dorsal column, sir.
Okay.
Okay.
Or any visual field defect, sir.
Okay.
Okay.
Or it could be any myopathies or orthopedic problems.
Okay. Dr. Naveen, you can come in at any time.
Yes, yes.
Okay. So now, okay, you proceed. Next symptom, you can go on and.
Okay, sir. I'll go to the next slide, sir. History of present.
Yeah.
This slide itself, other symptoms are there. We just see chaotic movements in both upper limbs into 5 years.
Yes, sir. It could be tremors, sir, because of chaotic movements.
Okay.
It could be resting or intentional or action tremors, sir. And difficulty in using, sir.
Okay, when you summarize, we'll see. Okay, carry on, then we'll see. Next slide, we'll go on.
Okay, sir. History of presenting illness. The patient was apparently normal 7 years ago. Thereafter, patient developed unsteadiness while walking, which was insidious in onset, gradually progressive in nature, and swaying to both.
A bit slowly, so that I can follow up. Yeah. Okay.
Okay. Which was insidious in onset, gradually progressive in nature, swaying to both sides and back, associated with frequent falls, at least 2 per month, which is after which he's able to get up with support and continue her normal activities. The falls were not associated with head trauma, loss of consciousness, and involuntary movements. History of walking with legs wide apart noticed by the family members. In the course of time, in 3 years, unsteadiness aggravated that the initially required support from surrounding objects to walk for around 2 years, followed by requiring support of 2 persons for the past 1 year. No history of nausea, vomiting, ear pain, discharge, hard of hearing, and tinnitus. No history of aggravation of symptoms in the dark environment. So I'll continue, sir.
Yeah.
You told walking difficulty in the dark environments. What are you trying to say here?
So I'm trying to rule out dorsal column, sir, because in posterior column involvement, the symptoms will be better with visual input, and it will worsen on dark environment, sir.
Okay. You mean to say is that like diurnal variation? Morning it will be in okay, in the
it could
night
be
time.
diurnal variation, or sir, on closing eyes or opening eyes also there will be variation in symptoms, sir.
Okay. Okay.
Patient had complaints of chaotic movements in both upper limbs for 5 years in the form of unable to take food to her mouth. History of chaotic movements which increased while reaching for target such as glass utensils, which was absent at rest, present in both upper limbs. No history of difficulty in lifting hands above head for combing hair or reaching for objects above the head. Patient,
Does she have any this thing? Any difficulty in wearing the saris and this thing?
Sir, her difficulty in using upper limb is because of the chaotic movements, sir, but she doesn't have any weakness, or she's able to do all the movements.
Okay.
But her fine movements are affected because of the irregular movements in her upper limb.
What are the other term we can use for instead of using chaotic movements? What are the other term we can tell?
Tremors.
Okay.
Could be intentional tremors, sir, because it is reaching for target and it is absent at rest.
Okay.
Or it could be rubral tremor, sir, present only in upper limbs.
Okay. Which are conditions like rubral tremor?
So Wilson's disease.
Okay.
Multiple sclerosis, sir.
Okay.
If the red nucleus is involved.
Okay. What is the common this thing? Routinely we see the case in medicine OPDs and neurology OPDs. Yeah, they have this thing disease. After that, it will post of the disease we'll have this tremors. Which disease is that?
So Parkinson's. You're asking about rubral tremor, sir?
Rubral tremor, yeah. Common disease. You told this thing that is accepted. I'm not telling anything. Any other thing?
Stroke, sir. Stroke involving the red.
Yeah. Okay. What will be the characteristic of rubral tremor actually?
So wing beating tremor, sir.
It is unilateral. Okay.
Bilateral.
Oh. Rubral tremor.
Bilateral involvement, sir.
Rubral tremor is bilateral.
Yes, sir.
Are you sure?
Not sure, sir.
Okay, continue.
Patient had difficulty in using both lower limbs for 5 years. History of difficulty in walking, which has progressed from walking with support of surrounding objects for 2 years to walking with 2-person support and unable to stand without support for 1 year. History of unable to get up from squatting position or from chair without support. No history of difficulty in wearing or gripping chappals, insinuating foot into and out of the chappals.
Okay, if we have weakness in the wearing and gripping chappals, what all structures will be involved?
So in first, if they are not able to locate the chappal itself, it could be because of posterior column involvement, sir.
Good.
If they are not able to insert their feet into the chappal, it could be because of distal muscle weakness.
Okay.
Small muscle of the leg, lower limb weakness.
Okay.
Or it could be any spastics or any strokes or vascular causes.
Okay.
If after inserting into chappals, it is slipping out with consciousness, it is motor weakness, motor loss.
Okay.
If it is slipping out without consciousness, it is sensory loss, sir. You're not able to feel it.
Okay. Continue.
No history of difficulty in rolling over the bed or getting up from the bed, lifting the head off the pillows. No history of stiffness, weakness, flailness of the limbs. No history of any abnormal shortening of limbs, muscle ache, twitches, or tenderness. No history of any diurnal variation of difficulty in using upper and lower limbs. History of heightened emotional reactions to normal or minimal stimuli for the past 2 years. History of
Can
dysphagia
you
to
tell me
solid.
what do you mean by heightened emotional reactions?
Sir, emotional liability, sir. She was. She used to become very. How to say? Sir? Even for minimal stimuli, she cries a lot and she becomes. And even small this thing, she gives a height. They give typical history of exaggeration of her emotions, sir, for the
Okay.
past 2 years.
Okay.
Any particular reason you are attributing that to?
So it could be pseudobulbar palsy, sir.
Mm,
Emotional liability.
Why do you want to jump in like that? So
yeah,
she's anyway, she has medical problem,
yeah.
and
Depression or this
yeah.
thing.
So always think about common things and then try to connect. Okay.
Okay, sir. Okay. History of dysphagia to solids and liquids for 6 months, both with equal intensity, which was immediately followed by cough. History of frequent visits to nearby hospitals in view of cough and breathlessness post food or liquid intake.
Now the solids and liquids, did they both start simultaneously or?
So initially it was liquid, sir, but within like 2-3 months it was for both. So she had difficulty in swallowing both.
So then you can present like that. No, initially she had difficulty.
Liquid, sir.
Yeah.
But they're telling only for very minimal. Yes, sir. Initially liquids and then solids, sir. But currently both equal.
Okay, but she's having cough, but she's able to swallow.
Yes, sir. She's having cough, but she's able to swallow, sir.
Okay.
History of change in character of speech for the past 6 months in such a way that she had that the words had multiple breaks in between syllables. No history of difficulty in understanding the spoken words, repeating the words. She was able, negative history. She was able to feel clothes over her body. She was able to feel hot and cold water while bathing. No history of numbness or pins and needle sensation in limbs. No history of walking on cotton wool sensation. No history of neck pain, back pain. No history of shock like sensation passing over spine while bending the neck. She was able to appreciate smell, able to see distant and nearby objects. No difficulty in identifying colors. No history of difficulty in moving eyes up or down or from side to side, not associated with any pain on eye movements. No history of double vision or any head tilt. No history of drooping of eyelids. Patient is able to chew the food, able to appreciate sensation over the face. No history of angle of mouth deviation or drooling of saliva. She is able to feel the taste. No history of tinnitus or difficulty in hearing. No history of nasal twang of voice, hoarseness of voice. No history of difficulty in shrugging of shoulder or side to side movement of the neck. There's no history of palpitation, excessive sweating, lacrimation, dry mouth or dry eyes. No history of postural giddiness. Able to appreciate the bladder fullness. Able to initiate and control micturition. No history of loose stools or constipation. No history of weight loss in the patient.
You already told she has a postural problem, no? So how do you check for postural giddiness here?
No, sir. By history, I asked like when she's changing her posture, she's having any complaints of giddiness. She says she doesn't.
But she's able to assume the erect posture. She able to.
With support, sir. Only with support. With support, she's able to stand and these things.
So what do you have at the back of your mind when you ask about this postural giddiness?
So autonomic involvement is present or not? I want to rule.
So how will you rule that out? Autonomic giddiness.
So orthostatic hypertension, sir.
That's what. How will you
ask?
Or how will you measure that?
Sir, while supine, we will measure their blood pressure, sir. And in sitting and standing after 3 minutes and 5 minutes, sir.
Okay.
And
So
if there is a, sir?
Yeah. Now, how long does she take the patient to stand up? Did you
So
ask
3
her?
minutes.
No, this patient, this particular patient.
So
How long
currently
does she-
she's standing with the support only, sir. She's not able to get up on her own.
Yeah, then you'll not be able to comment about that, no?
Yes, sir.
Okay.
Because it will take time. Okay, sir.
Okay. Proceed, yeah.
No history of loss of consciousness, altered sensorium. No history of memory disturbances. No history of delusions and hallucination. No history of neck stiffness or pain. No history of heavy metal exposure. No history of any swelling or injury to the hips, knees, and ankle.
Which
No
heavy
history.
metals are you looking for?
It's a lead, sir.
Which
Okay.
industry? Yeah, lead and what industry you're looking for?
Painting.
Or in other words, how can an individual be exposed to heavy metals?
So by working in factories, a paint factory,
Okay.
Okay.
or
Or how
mining,
can
sir.
Okay, mining. Okay. So what heavy metals can produce neurological problems?
So
In what way?
lead can produce peripheral neuropathy, sir, and atrophy of the cell.
What
Okay.
type of Yeah. Okay.
Sir?
Yeah, sorry for asking something.
What apart from lead, any other metals?
Arsenic, sir.
Okay.
Mercury.
Okay.
Uh, I'm not sure, sir.
Okay. Continue.
Okay. No history of fever, abdominal pain, or recurrent respiratory tract infections. Past history, there's no history of similar complaints in the past. She's a known case of hypothyroidism for 10 years, for which she's
Some
taking.
patient has say recurrent. So what? Why did you ask about this recurrent abdominal pain? Is there any connection between nervous system and abdominal pain? I mean, would you like to connect in some way?
Recurrent respiratory tract, sir, or abdominal pain?
Abdominal discomfort or pain.
Abdominal pain. So porphyria.
Yeah.
They can,
Good. Okay.
then any enzyme deficiencies, sir? Any inborn errors?
Asking some questions, you'll be having something at the back of your mind, right?
Yes, sir.
So yeah.
Is there any association of any diseases?
With abdominal pain, sir?
Yeah. Patient has abdominal pain and ataxia. Any diseases comes to your mind?
Pain. I'm not sure, sir. Alcoholic.
Yeah.
Okay.
Alcoholic pancreatitis.
Okay.
And alcohol can also cause cerebellar.
Okay. Any this thing?
Sir,
Any infection?
malabsorption syndromes and B12 deficiency can cause cerebellar degeneration and ataxia, sir.
Okay.
Malabsorption. What other vitamin deficiency can produce neurological? I mean, ataxia.
B1, sir. Thiamine. B6.
Other important. E. Vitamin E. Yeah. Okay. Yeah. Okay. Proceed.
Past history. No history of similar complaints in the past. Known case of hypothyroidism for 10 years, for which she is taking tablet L-troxin 75 microgram 100. No history of type 2 diabetes, systemic
How can
hypertension.
hypothyroidism produce neurological problems?
So hypothyroidism can reduce the neuronal activity, sir. And
Yeah.
also in Hashimoto's, it can also cause reduced myelin synthesis and demyelination, sir.
Okay.
And in Hashimoto's autoimmune, the autoantibodies can cross-react with the myelin and cause demyelination, sir.
Okay. Now, how can this produce unsteadiness? Can any way it can produce any
Uh,
of your symptoms of this, this disease and this patient? Can
yes, sir.
hypothyroidism produce any of the symptoms?
Yes, sir. It can cause cerebellar degeneration. That is one way, sir. The other way is neuropathy, sir.
Yeah. What neuropathy?
A peripheral neuropathy, sir.
Okay. Another way, sometimes hypothyroidism can also be associated with B12 deficiency. Okay.
Okay, sir.
So
Okay.
that combination is also possible. Okay. Yeah.
Okay.
Proceed.
Okay. No history of type 2 diabetes mellitus, systemic hypertension, seizure disorder. No history of any previous surgeries, hospital admissions, chronic drug intake, alternate medications intake. History
Can you
of
mention a few medications? Can you mention a few medications which can produce these problems?
sir, Siddha medications can increase the heavy metal in the blood.
Okay. There's unsteadiness and the cerebellar type of problems or ataxia for that matter. Anything, any of these medications?
Sir, phenytoin, anti-epileptic drugs, lithium,
Okay.
Okay.
chemotherapeutic drugs, 5-fluorouracil,
Okay.
and methotrexate, sir, metronidazole.
Okay. Okay.
Okay.
Yeah.
History of okay, sir. History of COVID vaccination, 2 doses done. Birth history, the patient was born, a second born of a non-consanguineous marriage. It was a normal vaginal delivery at hospital. Cried immediately after birth. History of breastfeeding up to 1 year of age. Personal history, the patient consumes mixed diet, normal sleep pattern, reduced appetite, normal bowel and bladder habits, menstruating, having regular cycles, has one son, 28 years of age, who lives normally with no complaints, no history of drug or substance abuse. Family history, history of similar complaints in father and paternal aunt who had similar unsteadiness while walking as of that of the patient and died around 60 years of age. Other details and the cause of death were unable to be recalled by the patient. This is the pedigree chart, sir. The patient's father and paternal aunt had the disease, sir, but his son as well as her sister had no manifestations. Her mother also had no manifestations. Summary of the history: 45-year-old female born of non-consanguineous marriage with complaints of insidious onset, gradually progressive, symmetrically progressive ataxia of the trunk, limbs, and gait, difficulty in using upper and lower limbs, speech disturbances, intentional tremors, dysphagia, and emotional liability. There's no involvement of higher mental function, cranial nerves, or autonomic nervous system.
Emotional lability, okay? Not liability, lability. Yeah.
Yeah.
So the differential diagnosis could be a late onset spinocerebellar ataxia or hypothyroidism, vitamin E deficiency, B12 deficiency, and A beta lipoproteinemia. The structures which can be involved.
Go back.
Yeah.
Yes,
So
sir.
now justify your thing, and one by one you try to justify.
Okay. Sir, late onset spinocerebellar ataxia usually has a younger age group onset, sir. So I include late onset, and these patients have a cerebellum involvement, sir. So since this patient has unsteadiness as well as scanning type of dysarthria according to history and intentional tremors, I can localize to cerebellum, sir.
Okay.
And because of the involvement of family history, it is an autosomal dominant condition, sir.
Okay.
So I have gone to spinocerebellar, late onset spinocerebellar ataxia, sir. Hypothyroidism, because she's already known case of hypothyroidism, there could be any peripheral neuropathy or cerebellar degeneration or associated B12 deficiency, sir. Vitamin E deficiency can also cause peripheral neuropathy, sir.
Okay.
which is
In
fitting with this.
each of this, you tell what are all the points
Points
in favor and
favor.
what points are against.
Points favoring, points against.
Okay, sir. Vitamin E deficiency, points in favor is ataxia, sir, and points against is that she doesn't have any other deficiency or any weight loss or any other symptoms of vitamin E deficiency, sir.
Okay.
And it
What
is
of
all, sir.
B12?
B12 points in favor is again only unsteadiness, sir.
Okay.
And points against is she's taking mixed diet. She had no history of any admissions for blood transfusion or any injections, sir.
Okay.
And there's no hyperpigmentation complaints or nail changes. And there's no pins and needle sensation in the feet.
Okay.
And A beta lipoproteinemia, again, because of it can cause vitamin E deficiency, sir. So again, so these three are less. That's why I've kept in last three, sir.
Okay.
Most probably spinocerebellar because she has history-wise she has features of cerebellum, sir.
Okay. Family history is
Unsteadiness.
positive. Family history is positive.
Family history is positive. It is not worsening on dark environment, sir.
Okay.
And there is also tremors and dysarthria, sir.
Okay. Okay. Next.
Okay, for dark environments, already the patient has difficulty in getting up, no?
Yes, sir.
So how will you? Very difficult to say, no?
No, sir. Initially, she told, sir.
Initial
She
stages.
was when she was walking on her own and had only frequent
Okay.
falls. That time it was just the falls were in the morning and night, and it had no.
So, okay, understood. So now we want to rule out all the differential diagnosis. No, now subsequently from this.
Sir.
Okay. Yeah.
By
Okay.
examination.
Okay.
So the possible structures involved could be cerebellum, posterior column of spinal cord, and proximal muscle groups. I've included proximal.
What proximal muscle groups you're trying to say here?
No, sir. She had a history of difficulty in getting up from the chair and from the squatting position.
Okay.
So that could be any extensors of the hip involvement, which can also cause incoordination.
Okay. Okay.
The etiologies again could be inherited ataxias, hypothyroidism, vitamin deficiency, autoimmune etiology, metabolic disorders, chronic infections, and toxin exposure. In this case, it could be the first four, sir: inherited hypothyroidism, vitamin deficiency, and autoimmune.
Why it can be congenital?
So the age of onset.
Okay.
And
usually in congenital means which age group is frequently affected?
It's in the first decade of life, sir.
First decade means age?
10 years, up to 10 years of age. And usually ataxia and congenital will be associated with cerebral palsy, sir.
Okay. Okay. Good. Next.
Okay.
Also, go back.
Yes, sir.
What do you mean by chronic infections?
Sir, HIV can cause cerebellar ataxia, sir, by JC virus infection.
Okay.
And then
which autoimmune diseases can cause ataxia?
Sir, anti-GAD and anti-gliadin, sir.
Okay.
2 antibodies can cause.
2 antibodies.
What are the acute infections which can cause this problem?
Yeah.
Acute infections. So, viral infections are herpes, Epstein-Barr virus, cytomegalovirus, post-viral, sir?
Common. Post-varicella, post-measles.
Lyme's disease.
Okay, varicella. No?
Varicella, yes.
Okay.
Yeah. Varicella and also post-varicella, post-measles. They can
Okay,
produce. Okay. Yeah. Okay. Yeah. Can proceed.
Okay. On examination, informed consent was taken. The patient was examined in a well-lit room with patient in sitting position. The patient was conscious, oriented to time, place, and person. Moderately built and nourished. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema.
What are the neurological causes for clubbing?
Clubbing. So there could be so hemiplegia, sir, can cause stasis and clubbing.
Okay.
And then lung causes such as small cell lung carcinoma can cause paraneoplasm in the CNS, sir.
Okay.
And then
Okay, proceed. Yeah. Okay.
height is 160 centimeters, weight is 60 kgs, BMI is 23.4. There's no neurocutaneous markers present, no peripheral nerve thickening, skeletal abnormalities, or hair loss. The patient's vitals, pulse rate was 90 per minute, regular in rhythm, normal in volume and character, no radioradial, radiofemoral delay, all peripheral pulses felt equally, no vessel wall thickening. BP was 110/70, measured in right arm in supine position, no orthostatic hypotension. Respiratory rate is 12 per minute, thoraco-abdominal type. Saturation is 99% under room air. Temperature is 98.4 degree Fahrenheit, measured in the right axilla. Coming to CNS examination, higher mental function. Patient is conscious, oriented to time, place, and person. The memory, immediate, recent, and remote is intact. The speech, the patient had a scanning type of dysarthria with multiple pauses in between, where the repetition was intact, reading and writing is intact, except in writing, the patient had macrographia, which was seen.
What is macrographia?
So the patient progressively writes in a bigger size. They start with normal size and they go to bigger size because they are not able to control their distal movement.
Okay.
Mini mental status examination 28/30. Mood and affect, emotional
What is
liability.
her education level? How much she studied?
Graduate, sir. High school graduate, sir.
Okay. So is there any connection between MMSC and?
Yes, sir. MMSC in illiterate person, the score is reduced, sir. It is reduced to 19, sir. I'm not sure.
Okay, okay, sir.
The total score is reduced, sir, out of which we grade the patient.
Okay. Okay, yeah, proceed. Yeah.
Okay. So cranial nerve examination. The patient is able to perceive the smell of coffee in both sides. The visual acuity, visual field, color vision, and fundus were normal. And 346 nerve, there was ptosis was not present. In extraocular movement, saccage was present in both eyes. The pupils was 2 mm, both reactive to light, direct and indirect light reflex was present, accommodation was present, and nystagmus was absent.
Does all ataxia patients have nystagmus?
So if MLF is involved, then the patient will have nystagmus, sir.
Okay.
And the types of nystagmus depends on the condition which is involved.
Okay. Okay.
Fifth cranial nerve, sensory over ophthalmic, maxillary, and mandibular divisions were intact. The motor, temporalis, masseter, pterygoids were normal, and reflexes corneal conjunctival was present. Jaw jerk, I was not able to elicit, sir. Seventh nerve, wrinkling of forehead, closing of eyes, nasolabial fold, puffing of cheeks, and angle of mouth were normal both sides. Sensory, the taste was preserved over the anterior two-thirds of the tongue. The tongue, sensation over tragus, and secretomotor, moistness of the eyes and tongue were normal. Eighth nerve, Rennie's test and Weber's test were within normal limits. Uvula, gag, reflex, palatal movements were normal, and uvula was present in the midline. Trapezius and sternocleidomastoid were normal. 12th nerve, tongue bulk and tone were normal, and the power of the tongue and tongue protrusion was also normal.
In which conditions we'll have 9th and 10th palsies with ataxia?
9th and 10th. So when brainstem is also involved, sir, when multi-system atrophy or any vascular causes, sir, ischemic stroke, hemorrhagic stroke.
Okay. 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 Next.
The bulk and motor system examination, the bulk 10 centimeter above medial epicondyle, right and left was 30 centimeter. 10 centimeter below olecranon process was 26 in right and 25 in left. 18 centimeter above patella was 45 in right and 45 in left. 10 centimeter below tibial tuberosity was 38 in both sides. The upper limb and lower limb tone was hypotonia in all four limbs and all muscles. The power of the patient in shoulders, it was 5 by 5 in all range of movements. In elbow flexion and extension were both 5 by 5 in bilateral upper limbs. Wrist flexion and extension was again 5 by 5 in right and left. Hand grip was 100%. Lower limb in the hip flexion, extension, adduction, abduction, internal rotation and external rotation was 5 by 5. Knee flexion and extension was 5 by 5. Ankle dorsiflexion and plantar flexion was 5 out of 5. And neck flexion and extension was 5 out of 5.
In which ataxia? Once again. In which
Sir.
ataxia that the dorsiflexion or plantar flexion we lost?
Sir, in Frederick's ataxia, sir.
Okay.
In SCAR type 1, sir.
Okay.
Sir, Refsum's disease, sir.
Okay. Okay, continue.
Okay. Superficial reflexes, corneal, conjunctival, abdominal was present. Plantar was extensor in both lower limbs. Deep tempon reflexes, the biceps reflex, triceps, brachioradialis, knee and ankle reflex were absent on right as well as left.
What if
Sensation.
the reflexes are absent? What
Yes, sir.
signifies it? What does it signify?
So it could be because the the motor output of the cerebellum is reduced, sir.
Okay.
Or it could be another element pathology, sir, such as peripheral neuropathy. Or it could
Okay.
be, we can think more towards vitamin deficiency such as B12, where there's subacute combined degeneration, sir, where there'll be peripheral neuropathy and ataxia.
Okay.
And so it could be a SCAR type 3, sir. Machado Joseph disease, sir, where there's peripheral neuropathy.
Okay. Continue.
Sensation, crude touch, pain and temperature were normal. Fine touch, proprioception, position sense was normal. Cortical sensations such as tactile localization, 2-point discrimination, graphesthesia and stereognosis were normal.
Okay. If suppose that if any of the sensation is lost, so
Okay,
what
sir.
type of any attack, leave this ataxia, if any ataxia
Okay, sir.
which has sensory loss, which ataxia will have?
Sensory, associated with sensory loss, sir.
Yeah.
Sir, B12 deficiency, sir.
Okay.
Vitamin E also can have peripheral neuropathy, sir.
Okay.
SCAR type 3s will have neuropathy, sir.
Okay.
Then, if cortical sensations are lost, we can think of multiple sclerosis, sir.
Okay. Any other thing?
Frederick's ataxia also lower limb
Okay. Anything in the card?
cord also. Ataxia with cord.
Golden days.
Any
CV
disease?
abnormalities.
No, one disease.
Spinal cord, sir.
Sir gave a clue.
Sir?
Equivalent to HIV in the olden days.
Yeah.
JV. Syphilis, sir.
Syphilis.
Tape
Yeah.
cells.
Yeah, correct.
Okay.
What does it produce?
You told the
Tape
tape-
Sir?
Yeah.
You told the term.
Term.
So it produces dorsal column is involved, sir.
Yeah.
What is that? You
What's
told
the
the
name?
term.
Name. You told the name now.
Tapes dorsalis. Sir.
Yeah.
Yeah.
Cerebellum examination, there was saccades in both eye. Truncal ataxia was present. A bilateral finger nose test positive. Rebound phenomena was positive. Bilateral dysdiadokinesia was present.
Okay.
Bilateral heel shin test was positive. Drawing a circle she was unable to do.
Okay.
Foot tap test was positive. Tandem walking also she was unable to do without support. Gait, wide based ataxic gait. Scanning speech present. Pendular knee jerk absent. Titubation absent. Romberg's she was unable to do. No extrapyramidal signs. No signs of meningeal irritation. Spine and cranium examination was normal. No carotid bruit or thrill. No peripheral nerve thickening. Autonomic nervous system, postural hypotension was absent. There was no abnormal sweating, and resting tachycardia was absent. Other system examination were within normal limits. CVS S1, S2 heard. RS normal vesicular breath sounds, no added sounds. Per abdomen soft, non-tender, no organomegaly.
Any respiratory symptoms will have ataxia. Any respiratory diseases.
So ataxia, telangiectasia, there will be recurrent sinopulmonary infections. Sir.
Cardiac, cardiac wise.
Cardiac Friedrich's ataxia, sir. Conduction abnormalities.
Okay. In abdomen.
Abdomen alcohol-induced ataxia, sir.
Okay.
Abdomen.
Okay. Okay. Thank you.
The thing is Whipple's also.
Whipple's
Already you mentioned a few.
Whipple's, yes, sir. Whipple's disease.
Okay.
So diagnosis: 45-year-old female, born out of non-consanguineous marriage with complaints of insidious onset, gradually progressive, symmetrical, progressive ataxia of the trunk, limb, and gait, with positive cerebellar signs, hyporeflexia, and hypotonia. There's no involvement of higher mental functions, cranial nerves, sensory system, or autonomic nervous system involvement. The probable structure which is involved is pancerebellum with its connections. The differential diagnosis, again, late onset spinocerebellar ataxia is my first diagnosis. Vitamin E deficiency, A beta lipoproteinemia, late onset Friedrich's ataxia, Refsum's disease, Rousey-Levy syndrome.
What's it? Go back. Yes. What? No. This next slide. Next.
DDs. Yeah.
DDs.
Yes, sir.
What is Rousey-Levy syndrome? What does it do with ataxia?
So it will have it's a Charcot-Marie tooth syndrome, sir. Type 1A.
Okay.
There'll be muscle wasting and gait ataxia, sir.
Okay.
And they'll also have other symptoms like pes cavus and skeletal abnormalities. They can also have areflexia. That's why I put in, because ataxia and areflexia.
So you come to diagnosis of late onset spinocerebellar ataxia, vitamin E deficiency,
Yes,
A beta protein, late onset Friedreich's ataxia.
Okay. Refsum's disease and Rousey-Levy.
Okay. Next.
Investigations: CBC RFT routine investigation, CBC renal function test, liver function test, thyroid function test to check thyroid status.
Okay.
Vitamin assays such as B12, B1, and vitamin E. ECG and 2D echo to check for any conduction abnormalities.
Okay.
MRI brain with whole spine to look for cerebellar flare or any degeneration or atrophy.
Okay.
Nerve conduction study to look for other causes of ataxia such as peripheral nerve sensory ataxia. Whole genomic sequencing because of the family history to find out the mutation and the cause and the repeat which is involved in spinocerebellar ataxia.
In this patient, anything was positive in the routine investigation?
Routine, no, sir. It was within normal limits, sir. Only in whole genetic analysis, her spinocerebellar ataxia type 1 CAG repeats was positive, sir. ATXN1 gene. Her MRI showed only cerebral atrophy, sir. No other significant finding.
NCS was done.
NCS,
Was
NCS
done?
was done, sir. It was normal only, sir. There was mild sensory neuropathy.
How will you manage these patients? For example, the patient has severe peripheral neuropathy and
sir.
ataxia. She has come to you. She has gone to some 6-7 doctors. She has come to you. How will you approach this patient with the symptoms?
Physical rehabilitation, sir, for these patients.
Okay.
Then for ataxia, there are newer drugs which are available, sir,
Okay.
such as riluzole, sir, which can be given, but none of the drugs are approved yet. Buspirone, valproic acid.
You
Okay.
Then,
mean new drug means riluzole is not a new drug, no? Maybe new application you mean.
new for
New
spinocerebellar.
application.
Yes,
Okay.
sir. And then there could be neurostimulation, sir. They could do non-invasive neurostimulation in the peripheral.
What all we can do?
So electric stimulation.
Okay.
I'm not sure, sir, about neurostimulation.
For this patient, did you ask for any cardiac symptoms?
Yes, sir. The patient had, I mentioned, sir, no palpitation or chest pain, sir. To rule out Friedrich's can have conduction abnormalities in 60% will have cardiac involvement, sir.
In spite of being emotionally labile, she doesn't have palpitations.
Palpitation, yeah.
Okay, so in present, you just think about all the possibilities. Huh? So,
okay, sir.
So basically, you've done a lot of extensive investigations, right?
Yes, sir.
So, but clinically, you feel your clinical diagnosis and things are matching, or?
No, sir. Usually, spinocerebellar ataxia should not have areflexia except for certain variants or certain types.
Yeah.
But this patient has areflexia. That is not matching, sir. And she also has a mild proximal muscle weakness, which is also not fitting with spinocerebellar ataxia, sir.
Okay, so how do you want to explain those symptoms or findings?
Areflexia I would like to explain with additional involvement of posterior column, sir. Sorry, sir. Additional peripheral neuropathy, large fiber neuropathy.
Okay.
And
but for peripheral neuropathy, what findings do you have? You told, okay, clinical as well as your NCS is also negative.
Yes, sir.
Normal. So that means, so clinically, what findings do you have?
So for peripheral neuropathy, clinically, she
only the ankle reflex, but then
only that. But even plantar is extensor. Areflexia and hypotonia only, sir. It's not fitting.
you're not able to explain that particular symptom, right?
Sir, yes, sir.
Can hypothyroidism explain those?
Yes, sir. Hypothyroidism can cause both neuropathy as well as cerebellar degeneration ataxia, sir. But because her investigations were within normal limits, I didn't include.
Another one, third something findings you told. Another one is the proximal muscle weakness, right?
Yes, sir. Yes, sir. Thigh muscle weakness, sir. Hip extensors. Because she was not able to get up from sitting position. Could be because of hypotonia itself, sir, because of the cerebellum output.
Okay.
Or it could be muscle weakness.
Anything else, Dr. Naveen?
Yes, sir. I think so.
Anything else you want to add to this? No, anything you want to add to the presentation or any comments on the?
Just one thing is that late. I'm
Yes,
not
sir.
very happy with this late onset spinal attacks. Why it can't be that either she should have not noticed symptoms early.
Okay, sir.
So that's the thing
Yes,
I was
sir.
thinking about it. That actually 37 years is telling the patient has noticed the symptoms, but my thing is that it should have started in the adolescent age also, but we don't know what exactly happened at the time.
You told it started at what age, Navi?
She's 45-year-old, sir. It
Now
started 7 years.
37, sir.
37.
But why did she discontinue the schooling after the thing?
No,
You told
sir.
she has studied up to 12th standard or
12th
something.
standard,
Right?
no. Why she didn't
That is
do
a
after?
fan. That normally only she
Normally okay. She's unmarried, right?
she's married, sir. She has one.
One kid, sir. She's
One
married.
kid, married and a kid.
Yeah.
Okay.
Uh,
Okay.
Her father also had similar complaints, sir, but they didn't evaluate.
Okay.
Her sister doesn't have any complaints, sir.
Okay. So what is the inheritance of this condition, spinocerebellar ataxia?
Spinocerebellar is autosomal dominant, sir. Friedrich's is autosomal recessive.
I'm not asking everything. Just.
Okay.
Okay. Shall we wind up then, Dr. Navi? Today,
Yes, sir.
any special comments you want to?
Yes, sir, we can wind up, sir.
Dr. Saravanan too. Dr. Saravanan?
Sir.
I'll call, sir.
Yeah. Okay.
I'll call, sir.
Yeah. Okay.
சார் கூப்பிடுறாங்க சார் மீட்டிங் முடிஞ்சு அப்படியா சார் ஓகே சார் சார் சரவணன் சாருக்கு அவங்க கனெக்டிவிட்டி இல்லை போல முடிச்சுக்க சொன்னாங்க சார் தேங்க்யூ மட்டும் சொல்லி
தேங்க்யூ டாக்டர் நவீன் ஃபார் தி brilliant interaction and very informative talk.
Okay, sir.
And, thank you very much. Thank you, Naveed. And Naveed, I just want to comment is that whenever you present, the question you should anticipate from what you're presenting. Okay, so you should next time you should try to prepare more meticulously on that regard.
Okay.
And try to keep it simple also. Now, if I don't bring in all the theoretical aspects, so try to keep it simple. Repsums and all, we don't know how much common, and based on the locality also, it matters, right? So all those things we try to shortlist to whatever is common. Okay.
Okay, sir. Okay.
Okay. Thank you. Good idea. Thank you. Dr. Naveen, you want to add something?
Nothing, sir.
Thank you.
What I thought it was, sir, actually. Thank you.
Okay. Thank you.
Thank you.
Good day. Bye.